Okay, well, good evening, everyone. Welcome to the AO Trauma Hand and a North online series. We're going to be talking about soft tissue coverage of the hand and wrists. We're going to be covering skin substitutes, biologics, biosynthetic, and synthetic options. And so I'd like to introduce our faculty. I'm Sonu Jain at the University of Cincinnati. We have Dr. Jay Bridgman, who is from Columbia, Missouri at the Hand and Myofascial Surgery Group. And then we have Kim Mazzara, who's at Texas Hand and Arm Center in Dallas, Texas. And these are our disclosures. So complex upper extremity wounds present a significant reconstructive challenge. There are multiple strategies to address these defects, ranging from grafting to flap reconstruction. One option along the reconstructive ladder is use of these dermal substitutes. Today we'll review the different types of dermal substitutes by biologic and synthetic, and discuss how to select the appropriate option based on the clinical scenario. At the end, you'll understand the clinical indications for dermal substitute use, recognize the key properties and differences among these dermal substitutes, and identify appropriate clinical scenarios for their use in the upper extremity for reconstructive purposes. Here's our overall agenda. And I would like to bring your attention to our AO North America Trauma Online series. So this is our Series 2, Soft Tissue Coverage of the Hand and Wrist. Upcoming online webinars include the one on April 16th, Classic Coverage, Local and Rotational Flap Options, and then April 30th, the Journal Club. And then our Series 3 for the arthritic thumb includes traditional treatment on May 21st, joint replacement, PRP denervation of the thumb basal joint on June 11th, and on June 25th, we have a Journal Club. Here are some upcoming courses that we have via AO North America Hand, and includes the Hand and Wrist Fracture Management course in Dallas, Texas on March 28th. We have our Hand and Wrist course, Simple Fractures to Mangle Extremity, Becoming the Complete Hand Surgeon in San Diego on May 14th to 16th. And we also have the Hand and Wrist Fracture Management course in Ann Arbor on June the 6th, all in 2026. Okay, it's my pleasure to introduce Dr. Kim Mazzara, who will give her talk. Kim, take it away.
All right, great. Thank you, Sonny. I appreciate that. So let me get myself here in the right mode. So my task tonight is to kind of present an outline of kind of what's available commercially and what's kind of being developed. It is a overwhelming buffet, if you will, of choices in skin substitutes. And so I'll try to organize that a little bit and break it down and hopefully make a little sense so we can keep it organized in our minds. I mean, one of the biggest challenges I think I find personally is, you have someone come and introduce a new topic, or someone comes and introduces a new product, and it's really hard to become kind of jumbled in your mind about what does this one do? What does that one do? What is that one made of? So it can be a little confusing. So hopefully this overview will help a little bit. Our objectives tonight is to kind of recognize the general categories of what is available. And instead of focusing on the names, because names come and go, I chose to focus more on categories, just to help kind of understand what's in one category may have 20 or 30 products in that particular descriptive category, but it's better to know the category, I think, than to worry about the individual names. And also understand the difference between those categories, and why would you choose one versus another, what characteristics apply to a particular wound, and what are the indications for these products. So just to start, kind of in just a very simplistic organization, we kind of think about when you're having a patient, you have a wound, what is it that you're trying to substitute, right? What is it that you need? Do you need epidermis? Do you need dermis, or do you need a compound? Do you need something that contains both? Do you want it to be a temporary placement just to stabilize the wound and hopefully provide some healthy wound bed for later skin grafting? Or are you trying to do a permanent substitute that requires only one surgery, perhaps, and not a second surgery or further skin grafting options? And then where is your product coming from? I mean, do you feel comfortable working with biologics, with human or animal, sources, or a synthetic that has none of those? There's pros and cons. We'll obviously go over those in a little bit. Or do you need something that has both, that has a biosynthetic feature? So you have hopefully some of the best of both of those categories. And this just kind of gives it just an overview of those categories so that we can kind of dive in a little deeper to some of those. Just of interest, I wanted to share kind of a little bit about this product market. There are currently, it changes, weekly, I think, as far as things that are coming on the market, but there's probably 75 to 100 products that are commercially available now, and probably at least 100 to 150 that are in various stages of research and development, including like 3D bioprinting. That's becoming a big thing for the synthetics, and bioengineered dermoepidermal scaphoids. There's a lot out there. So I think again, just kind of understanding, this is kind of where it starts. We have our allogenic, our genetic, we have our auto. We're not going to talk about autografts tonight, obviously, but then our animal sources are xenografts and how they're processed to get to the final endpoint of having a healthy healing wound. And this again, looking at just trying to make it a little less confusing. When we decide that we have a large wound that needs care, then we come down and we're looking at, okay, what's commercially available, what's under development. And these just kind of is a broad category of, where these cells and where this tissue comes from. So placental membrane tissue, this is obviously human donor, cultured epithelial sheets, dermal templates, epidermal templates, and then composites. So again, knowing kind of what you need and how deep your wound is, etc., will help to understand where to go with your choices. Looking at some of the economics of this, which I'm not sure how things are perhaps in Europe or Asia, etc., but in the United States, there is, we're kind of our system is kind of controlled, if you will, or regulated by Medicare, by CMS. And so this is a kind of a look at from a Medicare spending per year from 2019 to 2024 in billions of dollars, the skin substitute reimbursement. And in 2019, you can kind of see where it was versus where we were in 2024. And this, again, as the technology gets better, and we love our technology, of course, so does the cost. And so that can lead to some considerations and issues with what is available and what one can use depending on the payer or the insurance company as far as reimbursement. And looking at kind of where in the world are most of these skin substitutes being utilized. And the dark purple at the bottom here is North America. So you can see that market has grown consistently and is projected to keep growing to 2029. And then Asia Pacific, which is the lighter blue aqua color here, is this probably the second largest growth market for skin substitutes. And lastly, looking at what type of wounds tend to make up the market for skin substitutes. And what we're talking about tonight, because of what we do, because we're trauma surgeons and we do trauma, the acute wounds are more the focus of this particular talk. But actually, in reality, it's the chronic wounds that take up the market share of these products. And that would include burns, venous stasis ulcers, diabetic foot ulcers, and other diabetic wounds actually are kind of more of the market share of skin substitutes. So looking at kind of transitioning to now, what would make a really good skin substitute? What would we like it to be? Well, we would like it to have minimal antigenicity and then be less likely to cause an immune response or to cause an inflammatory response. And so it would be not something that would kind of respond to tissue or reject the tissue. We would like the tissue to be fairly compatible with its structure and its basement membrane and such like that, to be close to skin as we could get. We would like it to obviously be a barrier to microorganisms and be able to keep the tissue bed moist and adhere to the tissue bed. Um, we would like it to be able to efficiently adhere to the wound surface. Um, and that is due to the fact that if you have something that doesn't adhere well, you can get a fluid collection underneath that layer, and then you can get infection and you can get problems with the health of the wound bed. So you kind of want a product that does adhere nicely and allows for ingrowth from the fibrovascular tissue in the wound to create that healthy bed that we need to either skin graft later or to heal. We'd like it to be easily accessible, meaning that we can get the product, right? Some of the human tissue is a little harder to get. Some of the allograft tissue, the supply isn't always there, and it can be hard to get from, a tissue bank or something like that. Versus, a synthetic product is just on the shelf, and so that can be a little more accessible. And then, of course, affordability. And that plays a big role in what one can use and what one can get. So I'm going to kind of structure the next few slides off of this particular flow chart and talk about, first of all, we'll talk about biologics, and we'll talk about ones that are, we're going to focus on allografts and xenografts. Cellular or acellular, if we want to have any epidermal component or just a scaffold. Then we'll go into our synthetics. So first, we'll decide, how do you choose, when you're looking at these products, how do you choose the product? What factors or features or variables do you need to consider? Well, the wound characteristics, of course. Depth of the wound is important. Do you need a dermal layer replacement or an epidermal layer, or do you need both as a bilayered construct? I mean, do you need a membrane, which is a flat, obviously your wound is flat and you can put a membrane on it, or is your wound more of a cavity and you may need a gel, or you may need a liquid formulation of the skin substitute in order to properly treat the wound that you're trying to take care of. The size of the defect is important. Are you resecting a basal cell carcinoma or a melanoma off the forearm and you have maybe a 4 centimeter defect? Or is this a burn situation and you're trying to cover the whole trunk or back area? So that is an important as far as size and the depth of your wound. Then the cellularity. Do you require a product that contains living cells, like in the amnion or the placental cells? Or do you just want an acellular scaffold to serve as a matrix for ingrowth of fibroblasts that you can then later skin graft? And then the duration. How long do you want this product to be in place? Do you need a temporary material just to prevent fluid loss and to stabilize the wound and prevent the wound from drying out if you have exposed tendons or exposed cartilage, etc.? Or are you thinking this is a one and done? You want a permanent construct that allows for tissue regeneration that you don't have to go back and deal with. And the type of wound, traumatic wounds, as we'll kind of look when we look through our cases later, we'll talk mostly about traumatic wounds and some other issues, but typically the traumatic wounds after an initial debridement tend to be pretty healthy and they have a pretty healthy bed versus like a burn wound or a diabetic ulcer or a chronic venous stasis ulcer. Those wound beds may not be able to be done in one stage because the wound bed is just not good. We first have to get a good wound bed before we can actually cover it. So you may need more of a temporary product for a more of a chronic wound versus just chewing kind of a one stage. The economic considerations, again, not to dwell too much, but it does play an important role. Through the whole spectrum of these products, they can range anywhere from $100 to $21,000 per application. And that's, 2025 data. So it's probably even more expensive in 2026. One thing that is important to us here in the US is our CMS or our Medicare oversight in January of this year just set a standardized rate of reimbursement at $127.28. Don't know how they actually got that, but that's what it says per square centimeter. So that means the reimbursement will be no more than that, you know, irrespective of what product is being used. That's how much they're going to pay per square centimeter. So, as you can probably imagine, the hospital systems are going to become very involved in product choices because they have to keep their overhead and to keep their product, their profit margins, and to prevent, losing money on these cases. So this is becoming more and more an issue. The hospitals are becoming more and more involved in what products they'll put on the shelf, and the surgeons, I mean, we can still obviously kind of rally and try to, make sure the patient gets the proper product, but it is becoming not just an easy, like, I want this, I want that, and the hospital says, okay, those days may be gone. And then again, the availability, if you need something that's really difficult to get and can't be obtained for weeks, then that's probably not going to be the product you want. Maybe something that's more accessible would be better for the patient. Surgeon experience, I think, is an important consideration because some of these products, the preparation may be kind of a multi-step preparation in the OR, or which side is up, which side is down. Have I seen this before? Have I used this before? How do I get this? How do I apply this to the patient? What do I have to do? So just be familiar with, and if there's a product that you've used, and you're very comfortable with, that's actually okay to continue using that. So just looking at our biologics, we'll go through this kind of quickly. We have the allografts. So this is our biologics section, allografts. And again, dermis and epidermis. They're durable, easy to use. Many are stable at room temperature. Some of the donor tissue is, placenta and amniotic tissue is very popular, and a lot of products do have this. It's rich in collagen, elastin, fibronectin. It does come in injectable forms or gel forms, so that makes it easy for those cavity wounds. And again, you can get acellular or cellular. You can get fresh amniotic membrane, which has viable cells, growth factors, and cytokines, or just an acellular processed layer that just has a basement membrane and an epithelial layer for you to use as a scaffold. The pros of human tissue are, of course, it has great wound protection. It's a natural structure. It can be stored without necessarily, not all of them have to be frozen, so they can be stored on the shelf, and it can be considered a permanent treatment, so you don't have to go back and plan a second stage. The cons are even though it's processed, still can have disease transmission because it is human tissue. An immune reaction, again, the availability may not be easy and the cost may be difficult to deal with. Second category of the biologics, animal tissue, are xenografts. Most commonly, it's going to be bovine, cow, or porcine pig. Although there are some of the products that have horse cells, sheep, and tilapias. Apparently, besides being delicious for the meal, the skin can be very wonderful for wound care, and so that's another xenograft that is used. I myself haven't used that one, but in the burn world, I think it's used commonly. They act as a protective barrier. Also, they do have gel formulations for those wounds that can't accept a membrane structure. And they're a little bit more durable. And they can be used to cover exposed small areas of exposed bone, tendon, cartilage, and joints. Not obviously large areas would probably not be for skin substitutes anyway. The pros, readily available, effective barrier, lower cost typically, and it does decrease pain and healing time and decrease the number of wound changes necessary, so it can be good for the patient. The cons are perhaps an infection risk from the animal tissue. It is typically temporary in most cases, meaning you have to go back and do a skin graft or some kind of coverage. And there may be an immune reaction. And then there are some cultural concerns depending on what area of the country or world you may be in. There's some religious or ethical concerns, and not every patient would be comfortable with this type of a biologic. So we've talked about that. Now we're going to go down and talk about our synthetics and biosynthetics. So the synthetics, typically they contain some form of fashion of hyaluronic acid in a silicone. as a protective layer. The scaffold is made of bioabsorbable polymers, and there's no tissue or cells like human or animal cells in this. So this is completely a synthetic product. Um, then there's the combination of natural and synthetic, and that can be very helpful. It's a lot of the more commonly used products that we use here in the US are in this particular category. So you have a bilayer structure with an animal cells and silicone typically. And they also can be made with human fibroblasts. But I think probably a really common one would be the animal and the silicone and the kind of bilayer structure. There are a combination of animal and human sources that exists as well. And that's usually made of like a type 1 collagen with a bovine type 1 collagen and human fibroblasts that are have various sources from where those fibroblasts come. So the pros, it's readily available, typically off the shelf. Because the synthetic is kind of manufactured, there may be more options regarding thickness and the type of material. You can kind of pick and choose because there's just more options with that versus our biologics. The products tend to be very uniform, which in a biologics may not be exactly that. And there's a decreased infection risk. Cons are typically these are expensive, so the high cost. Lack of features like sweat glands and hair follicles that may down the road be an issue, especially for very large areas, depending on where the body that this graft would need to be done, can be a downside. The synthetics don't always adhere as well to the wound bed, so that can be a little disappointing. And then most of them as well are temporary, so you do have to kind of plan a second stage to go back. So just kind of in the end here, just looking at some take-home points, there are so many available, over 200 probably in total available, and there's no way that anybody is going to remember every name and every one of those. So just become familiar with the general types. Know your biologics and your synthetics. So know that that's kind of your first, I guess, fork in the road on your flow chart. Which one of those do you want? Know if you want it to be permanent or temporary, and then know if you need an acellular or a cellular version. And just knowing those three things can help guide you to where you're at. And again, cost is increasingly becoming important as a driver. And what I would advocate for you to do is become familiar with what your hospital has or what your hospital will allow to be brought in. So you may talk to your biomaterials people. You may talk to your hospital administration or your OR administration and see what they have or what they will be willing to get. If you want a specific product, be proactive. It doesn't mean you shouldn't advocate for that, but it takes sometimes days or even a week or more to get approval for those things. And the hospitals are kind of regulating these fairly closely. So you may have to have, there may be a process to get this product in your hospital. If your case is tomorrow and you don't have it, you might be frustrated that you're not going to be able to get it. But I think you can advocate for these products. Our technology is wonderful, and it's nice if you can get what you want. So that's what I have for everyone.
Thanks, Kim. That was a great talk, a great overview, a lot of great points. Costs are definitely important, and thanks for putting that plug in for what CMS is putting. I did not know that.
Yeah, that's
I
pretty amazing, actually, when you think of it. Um, that just happened in January. So for us here in the US, that's going to be a big deal, I'm afraid, because if Medicare only is going to basically reimburse $128 per square centimeter, um, if there's a product that is $21,000 to get into the hospital, I can see the hospital's not going to be crazy about allowing that product to be brought in. So that's definitely going to be a driver of, I think, of our, of what we can use.
no, absolutely, absolutely. Well, next we have Dr. Jay Bridgman, who's going to be talking about acellular dermal regenerative templates. Jay, all you, man. Thanks.
All right, thank you. Tim, I thought that was great. And as I get started, we didn't really have many questions from the audience, but one question I had is, are there some products that you think are patients are more prone to develop an inflammatory response than others that come to your mind? I know I've tried some and they seem to work well in most patients. And then I'll have a one-off where the patient gets really swollen or red. It's not infected, but it seems like they've developed a kind of fairly, significant inflammatory reaction. Are there any that come to your mind that are kind
Well,
of
the
ones to be
ones I've
careful
had
of?
experience with are the placenta and the amniotic tissue, and those I've actually had some inflammatory responses that have not been easily managed with those products from those those base cells. So I mean, I think if if you're using a cellular matrix, that's probably going to increase the chance of developing,
Mm-hmm.
kind of an inflammatory response. But of those biologics, the ones from the amniotic tissue are the ones that I've seemed to have more trouble with in my own
Okay,
experience.
sure, sure. All right. Well, we're gonna kind of transition to what the product that I've had more experience with is a cellular dermal regenerative templates. And I'll start with a case. So this is a 71-year-old male, not too healthy. He's had this chronic posterior ankle wound that you can see in the upper right hand corner with exposed Achilles tendon. He was referred by a local wound care center, and just the treatment plan that they had embarked on was not working. The wound was not healing. The Achilles tendon now had purulent uh, drainage and foul smell, and he's referred to me with this wound to see what we can do to try to help him. Fortunately, he had no exposed fracture of the ankle. There was no exposed ankle joint. It's just kind of the exposed Achilles tendon. So, when I'm thinking about the goals for this type of wound, well, of course, we want the wound to be healed, but it needs to be durable. Sometimes our treatment plans lead to a healed wound, but it's not durable, and patients will have chronic issues with the wound breaking down with shoe wear or as they become more active. Ideally, any treatment plan, we'd like to have early mobilization, and we want the tissue that we get to heal there to restore form and function. Some of the goals that I think of are ones to try to find a treatment plan that has a lower complication profile for that patient, such as this person. If you think about the patient profile, an elderly patient, what kind of surgeries would they tolerate? And so for this person, I thought, well, definitely it needs to be staged. I mean, he's currently infected, so we're going to have to do some type of staged treatment. My thought was that he's going to need to be admitted. He'll need serial debridements. We want to try to transition from an infected wound to a stable wound that's not infected. A big question for myself was, is it possible to even save the Achilles? Like, should we abandon trying to save the Achilles for this person if it's completely infected? And then if we get to a stable wound that's not infected, what type of reconstruction would we consider? The reconstructive ladder is kind of helpful for learners to think about what are the options available, but maybe the reconstructive elevator is a better concept because the patient, we don't want to try more simpler treatment plans that fail and then eventually go on to one that's successful that delays their care and usually has a less good outcome for the patient. So an elevator is just trying to balance form, function, and safety to choose the best treatment first. And for this person, I thought of, well, is there a local rotation flap? There are. I just didn't think his soft tissue envelope, if you see these other satellite wounds that he has, I thought that those would also complicate some of the local rotation flap options. He definitely was not a candidate for free tissue transfer. So then the question is there some other option? And for him, I chose an acellular regenerative, a dermal regenerative template. So what is this? This is the first FDA-approved product in the United States. It was designed for burn victims, burn patients when they had a significant percentage body surface area affected by their burn, and there wasn't enough donor site available for their wounds. It is a bilayer of type 1 collagen and glycosaminoglycans. The type 1 collagen matrix is bovine from the cow Achilles tendon. So it's an extracellular matrix of type 1 collagen. And then it also includes glycosaminoglycans, which are interestingly from shark cartilage, specifically chondroitin 6 sulfate. And this is known to decrease platelet aggregation and in that same cascade, lower cytokine production, decreasing inflammation. It's covered with a silicone layer But the whole purpose of it is it's a matrix to promote ingrowth from the native tissues of cells and vessels to form what is called a neodermis that would support later reconstruction. So what are the phases of this regeneration? The first is imbibition. So some of these things are kind of similar to the skin grafts, but the imbibition occurs within minutes, and that fluid from the wound itself is imbibed into the matrix. This fluid contains fibrin and other factors. And then over the first week, there's an ingrowth and migration of fibroblasts. And then towards the end of the third week, there's ingrowth of myofibroblasts with an ongoing maturation. And then you'll slowly see a color change clinically from kind of an off-white or gray color to a more pink color. And then the third phase is neovascularization, which occurs by the end of the fourth week. And what's known to occur histologically is that the matrix from the product is replaced by your own type 1 collagen matrix, and that with influx of cells and vessel formation, the color changes to a kind of a dark pink or salmon color. So there's definitely a clinical color change as the neovascularization is completed. And then beyond that, then this layer called neodermis is matures, and it can get actually kind of a little bit thinner and more pliant over time. Around the third or fourth week, the silicone layer will loosen. It's initially adherent to the bilayer, and then as it loosens up, you can see that there's kind of air between the silicone and the lower levels. And so then in the clinic visits, the silicone layer is removed. At that point, it's important to keep the wound moist. So I instruct the patients to do daily wet-to-dry dressing changes. As the neodermis has formed, they can go on to have skin grafting. And for my own practice, that's usually several weeks before they're on my elective schedule for a split the skin graft. So they have several more weeks for the neodermis to mature before the reconstruction is completed. But that's with a split the skin graft. And you can see with these drawings, the silicone layer is removed, the split the skin graft is placed, and then the split of the skin graft goes on to heal, completing the reconstruction. What complications to be thinking about? Well, similarly to skin grafts, you want to avoid hematoma and seroma formation that would lift the bilayer off of the wound. Many of these products are fenestrated, so it allows for egress of fluid. I prefer, well, you should place a bolster, but I prefer as a bolster using a negative pressure dressing. I think that not only helps prevent the hematoma and seroma, but also improves the speed at which the vascularization occurs. You definitely need a clean wound that should not have any evidence of infection. If it is infected, it would require debridement of all necrotic tissue, deep cultures, antibiotic therapy until the wound is stable and uninfected. But sometimes there's just poor incorporation, just like a skin graft where you have partial take of the skin graft. So what would that be related to? Well, maybe it is related to infection that was missed or wasn't treated significantly, or it's related to improper debridement. You need to be able to perform a debridement back to healthy tissue with punctate bleeding, even over exposed tendon, such as in my case, or exposed bone. Sometimes the poor incorporation is over a large area of the bilayer, or it's just smaller areas. If it's a small area, you can continue to wait over time because often the process of neovascularization is not uniform across the entire bilayer. So you'll see some incorporation that develops, and then you're waiting for some of the other smaller areas to incorporate, which could occur later. So it's important to think about the timing. So what are some of the evidence of the use in the hand? This is from 2009. Most of the papers that are cover this are small retrospective reviews or case series, but this is a retrospective review of 21 digits with average follow-up of 12 months from the Journal of Hand Surgery. And these were traumatic wounds with combined soft tissue loss, in which 19 of 21 digits had bone exposed, 8 had tendon exposure, 6 had joint exposure, 2 had metal implant exposed in the wound. And what were the results? Well, the wound sizes varied from 1 centimeter squared to 12 centimeters squared. And of the dermal template incorporation, they had 20 of 21 develop 100% incorporation of the template. The one that did not incorporate was a finger with multi-level trauma that went on to develop ischemia and necrosis, and so it was amputated. Of the fingers that went on to get skin grafting, that was occurred at an average of 24 days after the initiation of their bilayer, and 16 out of 20 went on to incorporate the skin graft completely. 4 of them had some partial loss of skin graft, but were treated with dressing changes and needed no other surgical treatment. So they still had fairly good results in that series. This is a 2011 retrospective review from Journal of Hand Surgery Europe. Similar numbers, 15 digits. The follow-up range from 10 to 37 months. These were also wounds that were related to trauma with exposed bone, joint, and tendon. And what were their results? With the same technique, the 13 out of 15 digits went on to have complete wound healing, and they were pleased with the overall reconstruction. So what are some pearls that I've kind of gleaned in my practice? A couple of things that I'd leave you with. Number one, sometimes patients have wounds that are not that difficult, need a skin graft, but there's exposed cutaneous nerve. So for example, around the wrist, the superficial branch of the radial nerve, or around the ankle, the cutaneous nerves around the ankle. And I found that if you place a skin graft directly over that cutaneous nerve, the patient's going to have ongoing nerve symptoms. There's just not enough protection when the skin graft heals. And so I think this is an ideal use for that. So it's one pearl that I'd leave with you, that the patients that I've done this technique have less nerve symptoms if they have a bilayer placed first and the skin graft staged at a later time. What about open joints? I would be very careful around an open joint. So for example, in these wounds for the fingers, those are smaller wounds, but around the knee or the ankle, if it's an open joint, there is a high risk of development of septic arthritis. Like, these don't really seal the wound necessarily. And so you need to be very careful. I would not recommend this be performed, say, around a large wound around the medial knee where there's an opening to the knee. I think those should be are better served and safer to perform a more definitive coverage early on, say with a rotational flap or with a free tissue transfer. And then lastly, consider that a patient may need future reconstructive surgery. If a patient needs future reconstructive surgery, that's what these pictures show, a local recent case that I took care of. Going back through a wound where the dermal regenerative template's been used, there's really no layers. It's essentially healed neodermis and scar tissue around, the median nerve at the wrist or the tendons at the wrist, for example. And so patients need to have nerve grafting at a future time, or tendon transfers later on, or removing scar tissue around tendons, tenolysis to improve motion. I would not consider this technique as one that you can go back several times for reconstructive, future stage reconstructive surgeries. But the fasciocutaneous flap is ideal for that. So for example, there's a patient that came to me, was referred for electrocution. He had been treated in a burn unit. They had tried a local rotation flap to cover this large wound over the volar wrist with exposed median nerve and the flexor tendons. The local rotation flap partially failed, so then they used a dermal template to cover the remaining area that did not heal. They did get everything to heal, but it was completely stuck in scar tissue. Like, he has major reconstructive needs for his hand in order to get excursion of the tendons. And I told him, if we go back, that was kind of what was referred to me, is to do the reconstruction. I told him, if we go back, we're going to need to go through all of this plane. It's not going to be something that we can close primarily. We certainly can't go through it several times. And so what I did for him was a free tissue transfer of the anterolateral thigh flap to replace kind of that scarred tissue. And this is something you can go back several times. You'll have excellent surgical planes that allow you to go back. So that's just one additional pearl. So what's the end of my case? We admitted this person over a week's time. Myself and my partner did several debridements. We were able to get deep cultures, targeted antibiotic therapy. We used negative pressure dressing changes between the debridement procedures. This is one technique that we were also able to inflow sodium hypochlorite, dilute sodium hypochlorite, to help clean the wound and treat like a surface treatment of infection. You can see over several debridements, we're now getting to where still some exposed Achilles tendon, but we're starting to see punctate bleeding, where there's no more of the purulent fluid, there's no more necrotic tissue. And then hospital day number 7, we placed the dermal regenerative template. And then I like to, as I mentioned before, I use the negative pressure dressing with a battery pack. So he's discharged from the hospital, just 1 week admission, and then discharged with a home negative pressure dressing with a battery pack. And then they return to clinic at 5 days. The pressure dressing's removed. They go to wet to dry dressing changes over the silicone. And then at 4 weeks, we have that neovascularization. You can see in the bottom right picture that the neodermis, now you see that solid sheet of that deep salmon color over the Achilles tendon. We have no more infection. We have a healthy bed of neodermis. And then he went on to have a split skin grafting, which is just, it's not healed yet because it just happened several weeks ago. But anyways, he did very well with this treatment plan to try to avoid, something more complex. So that's my experience. That's kind of some technical pearls, and I'll let you guys take it from here.
Thanks, Jay. That was a great talk. Great case. I think a key point from that is also really using your other tools to really get the wound cleaned up to actually create a good bed for your substitute as well, because it's not going to solve the problem just by slapping it on there and it's going to magically heal. So I think that's great. You use that irrigation, negative pressure, dressing to help kind of get things, set up for a good take. So that's great.
And while you're getting your talk ready, and one of the questions that came through on the Q&A, Jay, was which product or which category of products is good for over tendons? And your case kind of alluded to that just then. And do you have a preference for covering tendons?
Yeah, I think that I preferred, if the patient has peritoneum, I think you can use any product because they already have the peritoneum level. But if they don't, then I think some of the amnion, like amniotic based tissues work a little bit better for that. But as you mentioned, I've had some issues with the inflammatory response as well. But the key is early motion. Like if whatever reconstructive choice you have embarked on and they can't move their tendons, they're going to scar down, and then you're going to need to go back to try to improve their motion with tenolysis in the future. What are your thoughts, Kim?
Yeah, no, I've had the same experience. I mean, I've had that's kind of where I used most of the amniotic tissue derivatives was on, especially the back of the hand or the back of the wrist. Typically, it seems to be on the extensor side. And I think those products are really good for that. I mean, they're very thin and they're not bulky and they're very nice to cover a tendon with. But as in your kind of discussion, I mean, I've had some patients develop inflammatory reaction to those amniotic things, and not everybody. And when they work really nice. But I've had a few that didn't really work well, and because of the inflammatory response, then I ended up, it kind of just forms more scar tissue, right? And then you kind of you feel like you're, defeating your own purpose. But I've also used some of the bilayer if I didn't have the amniotic, at least I'm in the Dallas market. So in Dallas, the amniotic products are a little more expensive. I have to say, I don't know if that's that way in you guys' area, but sometimes the bilayer products that are, kind of a combination of the synthetic and perhaps bovine or some, a xenograft type, component, they seem to be perhaps a little more affordable and so maybe a little easier to get, but I've used that as well. They're a little thicker, not as nice and thin as the amnion, but yeah.
Yeah, I'll give my 2 cents. So I think that, with regard to tendon adherence, I mean, remember, you're putting this template over an open raw wound. It's going to stick to that tendon, it's because it has to heal to it. That's what it's supposed to do. Now, if you're going in and you're putting it as a tendon wrap or some other product, that's a different story because you're actually you're allowing movement during that typically, and also you've already created a little bit less adherence with that. Now, I think if you have the template in place, I usually try to have them move while it's in place, so that way you can actually prevent the tendons from adhering. So that's something you can do. You don't want to do that when you have a skin graft on that right away, So I'll go ahead and start my talk here on the bilayer biodegradable polyurethane dermal matrix and a couple other alternatives. I know there's a whole bunch that Dr. Mazzara talked about with that chart that she had regarding that, and we're not going to cover all of those. I think a lot of the ones that we see in our different institutions are kind of from what our burn attendings or burn surgeons have brought into the system. So I would definitely try to talk to them as well. So complex upper extremity wounds, you have exposed tendon, bone, or hardware, which limit graft successes. You have poor vascularity, which prevent reliable skin grafting. In these cases, sometimes flap reconstruction increases morbidity and operative time, depending on the scenario. Obviously, these are good choices for the right case, but these are situations where you're going to be considering using dermal substitutes. So dermal matrices create these vascularized wound beds, and the goal is to create durable coverage and preserve tendon gliding, right? Like we talked about. So you have the synthetic polyurethane dermal matrix. And so a little background on this. So you have a fully synthetic bilayer of dermal substitute, and BTM. We're not going to be using any trade names here, but there are different ones that are out there that are available. But open cell foam scaffold promotes this angiogenesis. You have a sealing membrane, which is also polyurethane, and that limits fluid loss and contamination. So the nice thing about these bilayers is that when you have them on, they do create like a little bit of a chamber to limit that fluid loss, and you get this vascularized neodermis that forms prior to the skin grafting, and you have low immunogenicity due to the non-biologic composition. So the key point is that if you're worried about inflammation, irritation, you want to look more at a non-biologic because they tend to have less of that of an issue. Indications: large, complex upper extremity wounds, exposed tendon, bone, or hardware. For trauma, burns, infection, again, alternative to flap reconstruction, you can use over the tendon repair sites to get that coverage. Pretty good outcomes from this. Wounds healed, 90% time with the, also greater than 90% integration rate, low infection rate. And the subset heals without grafting sometimes, and this can apply to other products as well, and reduce complications and costs versus biological matrices. So when we're talking about costs, the synthetics tend to be a little cheaper as well. One case that I have here is a 17-year-old male who sustained trauma to his right hand. He also had some fractures of his small ring finger, which were pretty bad. Those were went to the OR and had those pins at the same time that we took him to the OR for debriding his soft tissue wound. And this is following his initial debridement. And we put a wound vac over this initially. Again, I didn't want to put a skin substitute just yet because it was not clean enough at this point to really put that on. Again, this is a good time to put a negative pressure dressing. And then, so went to the OR again and debrided again. And at this point, it was good enough to really put the bilayer. So underneath this, you can see our bilayer, and on the thumb, I put a bilayer there, but I did not put any bolster there. That was just stapled in place. But on the palm, I did put a negative pressure dressing on there as a bolster. And then, so 1 week later, I took off the vac because you really don't need the negative pressure dressing after after about a week. That's usually enough time for that to really hold in place. And then this stays on as a bilayer. Again, you have a nice wound bed, as you can see, 3 weeks later, which is about the time that this takes to really be ready for grafting. And this is really bright red vascularized tissue. And you don't need to have anything other than just this staying on during that time. And you can really create a nice environment for skin grafting. And that's what we did. So went into skin graft that, and 6 weeks later on the left, you can see that the skin graft healed well, and it was pretty durable because 1 year later, when we saw him back during our follow-up visits, you can see that the skin graft has really contoured well, taken well, and we did this, you can see we did a recent Z-plasty of his web space contracture, or his thumb contracture on the palm. So it's a good option. I think one of the benefits of the synthetics is that it doesn't have as much an odor sometimes that you may notice with some of the biologics, and also it has less of a appearance of infection. Some of the biological ones will have a almost kind of like a not purulence, but almost kind of like a little exudate that appears to be like pus, and it can give the appearance of infection, especially if you have somebody who's getting care at an outside facility and they may may get calls. Oh yeah, looks like there's pus coming out from this, and something to drain that exudate. But you don't really have that with these synthetics. So that's kind of an advantage I've seen with some of those. Uh, Another product is the fish skin derived dermal matrix. So this is actually a Atlantic cod, and there's tilapia that's used as well, but this one specifically is cod, and it's an acellular dermal matrix derived from fish skin, and it preserves the extracellular matrix architecture. It has the omega-3 fatty acids, which are important to help with infection, or serve as an anti-inflammatory component. You have this porous architecture, which supports cellular ingrowth, and it's a biologically active scaffold. So the mechanism promoting angiogenesis and cell migration, again, like I mentioned, anti-inflammatory effects via the omega-3s, antimicrobial properties that are demonstrated, and they support granulation tissue formation and encourage epithelialization. These are historically been used more for chronic wounds, and now it's being more brought into the armamentarium for wounds that we see in terms of trauma. And then wounds with viable vascular beds and situations favoring single stage reconstruction. And you can make this argument for all the products we've talked about. I think there's also a movement for certain types of wounds or certain sizes of wounds to do them single stage, and some patients don't want to have a second stage. So some of them will help promote healing in those scenarios, and it can be used as an adjunct in complex wound healing. So you get improved cellular proliferation, migration, enhanced angiogenesis in some studies, complex wounds, and sometimes this may reduce pain and inflammation. But sometimes if you have a deep wound, you may need multiple applications with this. So this is a case that I had, which young lady here presented with the right dorsal wrist sarcoma, seen by one of our surgical oncology colleagues, sent to us to be available for reconstruction. And so as such, we were. And you can see here, she underwent a wide local excision by the surgical oncologist. And we wanted to wait for permanent margins before we did any kind of reconstruction for this, and also want to have a better wound bed for grafting. So it's kind of served twofold. Now, if you were to, you don't burn any bridges by using a dermal substitute. You could, if you are in a situation where you want to do a flap in these situations, but you want to buy yourself some time and create a good wound bed, you could also use this in that situation. And again, you could either let it heal. Depending on the size, you could do a skin graft, or you could, still do your flap if you want to. You don't burn any bridges. And in this case, you can see the fish skin here has porosity where it allows ingrowth of the tissue. And you can see within a week, it really already is incorporating. In 3 weeks, it's completely incorporated with good granulation tissue. And this is without a negative pressure dressing. I put simply a bolster on this. So you can see once she underwent skin grafting, it healed quite nice, and she did quite well. So another product is the bovine collagen dermal matrix, type 1 and 3, engineered porosity, and has a good degradation profile. Supports rapid cellular infiltration, early vascularization, designed to accelerate wound closure. So again, similar to the other products here, full thickness wounds, burn wounds, when rapid closure is needed, early autografting. This one heals a little faster as it's marketed as such for those cases. So as such, it's thought that these can be ready for even autografting in 7 days, and has a very good graft take. More consistent in terms of the profile compared to competitors, reduced wound contractions, and no observed infections in preclinical data. So you can see this case that I have here. This is a 91-year-old lady who was involved in an automobile accident, underwent an avulsion injury to her hand. As you can see, there's some ecchymotic skin. There's some loss of full thickness skin. Skin is very friable, so you really can't, it's even hard to even tack some of the skin down. And we underwent a stage reconstruction where we used this bovine collagen. And she actually did not, after we placed this, she actually did not want any further surgeries. And we just let the wound heal with just the collagen with the bolster, and then just dressing changes. And you can see here, she's actually healed it quite well without much contracture of the skin. And she actually can make a full fist and has good excursion of her tendons here, kind of answering the question that was asked earlier, that you can still get motion with using these products quite well. So when you compare these different products that we just talked about here, you can see that synthetic matrix, can be used for larger wounds. The fish skin is nicer for these smaller wounds, and then the bovines gives you a little bit of a faster pathway to grafting. So you kind of see what you want to get out of this. Again, these aren't hard and fast rules. These are just kind of an overall algorithm, but you can pretty much you could interchange all three of these for any of the wounds that we saw and probably get very similar results. And so, when you're looking at these clinically, you want to see what the defects, maybe consider synthetic matrix. If it's chronic or biologically active, then maybe consider the fish skin because of the omega-3s. And if you need something that's rapidly closed, then maybe use more of a bovine collagen matrix. So again, consider what you want to get out of it, balance cost, timing, reconstructive strategy. And take-home points here are that these expand your reconstructive options, and that these different products give you various advantages to getting coverage over your hand and upper extremity wounds, and appropriately select what works best for you. Okay.
That was great, Sonny. Thank you. That's great cases. There is one question, or actually a case from the audience, that if you guys are okay, we'll take a look at. It's a bike injury to the dorsum of the foot, deep laceration, extensor tendon lacerations, osteomyelitis. Skin grafts have been done. Now there's a recurrent small open wound on the midfoot dorsally. Suggested grafts or suggested skin substitutes for this particular case.
One of the things that it says because I was looking at the question too, but it looks like all the early injuries were in 1975 and this new wound is in 2015. So without looking at x-rays or knowing the patient, my first concern would be maybe they have osteomyelitis, because some patients who have osteomyelitis of a certain bone, they sometimes have it's get walls off, they get a involucrum and sequestrum, and then years later they'll develop a small wound and they'll get purulent drainage. So that would be, just with that history alone, without seeing patients or x-rays or MRI, I would think, is this person have osteomyelitis? That would be my first thought.
Mm-hmm. I agree. I mean, it seems it would be very likely that there might be something like chronic osteo that's just kind of showing itself and coming out through that. So I think you would need to stage this. I mean, you would need to, I think, perhaps study it if you wanted to look, but probably debride, take cultures, clean the wound, make sure that you had sterile wound. And then I do like the bilayer myself. I think it's a little thicker if you wanted to do something like that with the porcine and the silicone layer. Perhaps that would be helpful for this area if you had a clean base and maybe just a little bit of exposed tendon or exposed bone. I think that would work well. Alternatively, I guess you could use a xenograft like pig skin or something and then let it come back but you need something perhaps a little more durable if you're talking about even a small amount of exposed bone or exposed joint, I think.
Yeah, I think if you're going to take them back, do cultures, take a biopsy where they're just, if you're going to culture it, biopsy it as well. I think if it's a foot and you're going to be, it's in an area where it's going to be traumatized potentially by things bumping into it and things like that, I think having something that's a bilayer would be useful. I think using the polyurethane may be nice because it's cheaper. It has the durability as the glycosaminoglycans bovine bilayer, but it also doesn't have it's less likely to have that inflammatory or that infection, especially in the foot. So I think that we don't have to worry about there being like bacterial colonization of your skin substitute. So I think that may be a good case for a synthetic one.
One question that we had during your presentation was about the polyurethane. Like, when is it removed? Like, it's similar like at about 3 weeks, or is that
Exactly.
what you find?
Same as the dermal regenerative template. They work very similarly. Just the timeline is almost exact, and but it's just different material.
Very good.
That was
Excellent.
great.
So I think
Yeah, I think
awesome.
that
I
was
think we're at just a minute past our time here, but I don't think we have any other questions. So I want to thank our audience for joining us tonight on a wonderful discussion. I want to thank our faculty for great talks. This is great discussing these complex issues, and thank you so much. And we look forward to having you for our next online series. So thank you, everyone.
yes, thank you. Good night.
Thank you.
Good night.
Good night.